Chapter 39, Promoting Musculoskeletal Function by Mrs. Nakia Henderson. Lesson 39.1, Overview of Immobilization Problems. Theory objectives include: discuss the effects of inactivity on respiratory exchange and airway clearance, describe appropriate care of a cast as it dries, verbalize the difference among an air fluidized bed, low air loss bed, and continuous lateral rotation bed, listing the reasons for their use. Name at least 4 pressure relief devices that help prevent skin injury in immobile patients. Clinical practice objectives include: devise a plan of care for meeting the psychosocial needs of an alert, immobile patient, correctly care for the patient undergoing skin traction, use lift sheets and roller or slide devices to move immobilized patient. Immobilization. Bed rest may be required when patients are recovering from a variety of conditions: stroke, trauma, neuromuscular disorder, or chronic debilitating illness. Complications caused by immobilization include pressure injuries, pneumonia, bone loss, loss of function in the immobilized part. Special consideration: even though bed rest may be required, the complications can be severe. See systemic effects of immobilization in the Word document posted in your module. Preventing physical complications of immobilization. Encourage increasing fluid intake to 3 liters per day. Encourage adequate nutritional intake. Encourage increased fiber in diet. Administer stool softeners and laxatives as ordered. Encourage passive and active range of motion exercises. Encourage isometric exercises. Turn every 2 hours. Keep skin clean and dry, and use pressure relief devices. For children, diversionary activities such as games, movies, story reading. For adults, television, reading, crafts, crossword puzzles, and frequent visitors. Non-alert and comatose patients may also need support. There have been reports from patients who have come out of a coma who remember being talked to by others and remember voices. Always speak to the person as if he or she were awake. The goal is to keep the mind stimulated. Types of immobilization. Splints. They protect injured parts by immobilizing them. May be used as first aid before cast application. Types available: molded splints, immobilizers, inflatable splints, cervical collars, and traction splints. Inflatable splints may be used to control bleeding. They should be inflated until they can be indented 1/2 inch by fingertips. Immobilizers are made of cloth, foam, and Velcro. What would be some priority actions if someone experiences a fracture in your presence? Do not change the position of the injured part because further nerve damage could occur. Cover any open wounds with sterile or clean material. Use rigid splint material. Pad bony prominences to prevent pressure ulcers. Secure with wide bands of material to aid in immobilization. Elevate to decrease edema, and transport to a medical facility. Figure 39-1. It's a patient with a leg brace or splint. Reasons for leg brace or splint: lower extremity fracture, lower extremity stabilization, prevents further injury, and alleviates pain. Figure 39-2, wrist and forearm splint. Types of immobilization continued. Traction, a pulling force used to maintain body alignment, maintain fracture alignment, and relieve pain and muscle spasm. Can be skin traction or skeletal traction. Patients in traction should have an overhead frame and trapeze bar. Weights should swing freely without touching bed or floor. What would be the difference of care in a patient with traction who is 25 years old of age versus one who is 75 years of age? The younger person probably has more strength to help adjust self in bed and promote more turning. A younger person also may be more coherent to participate in self-care and breathing exercises. An elderly person may exhibit some confusion and not be as compliant in self-care, breathing, or may lack the strength to change positions. More reminders and actual assistance may have to be given. Also, skin care and assessment would be a priority. What important assessment would both patients require? A neurovascular check should be conducted every 4 hours. Traction. Skin traction uses Velcro boots, belts, halters, and slings, applied snugly to the skin, applied before surgery to help relieve pain from spasms. Main purpose is to decrease spasm accompanying fractures. Weight is generally limited to 5 to 10 pounds. Complaints of skin pain must be reported. Skeletal traction requires surgical placement of pins, tongs, screws, or wires anchored to the bone. Can support more weight than skin traction. Nurse is responsible for maintaining correct weight, alignment, and balance. Clear fluid drainage around pins is expected. Any sign of infection must be reported immediately. Circulation checks are performed every hour for the first 24 hours, then every 4 hours thereafter. Types of immobilization continue. Cast, used to immobilize an extremity following a fracture or orthopedic procedure. Skin is protected by a layer of stockinette, followed by a layer of padding. Cast is then applied. Can either be plaster or fiberglass. Cast must be protected during drying to prevent dents and uneven pressure, which can cause circulatory impairment and pressure injuries. Figure 39-4, hip spica cast. When handling a cast, use the palms of the hands and the flat part of the fingers. Swelling is common and if left uncontrolled, can cause circulatory impairment and pressure injury. Cast edges should be padded. Tight casts may be bivalved. Bars on hip spica casts should not be used for lifting or turning. What would be a sign or symptom that a patient is experiencing swelling with a cast? How would you respond? Pain is the most common complaint if swelling has occurred. Always perform a neurovascular assessment with complaints of pain. Report abnormal swelling to the physician. Try repositioning affected body part and provide elevation. Types of immobilization continued. External fixators. Pins, screws, or tongs inserted through one or more bones to stabilize fragments during healing. Metal inserts are attached to an external frame. Fixators allow patient to be more active. Device needs to be checked for stability every 4 hours. Pen care is required to prevent infection. What are the advantages of an external fixator versus a cast on an extremity? The external fixator is lighter and not as bulky as a cast. The extremity is visible for skin inspection. The skin is not wrapped and air is able to circulate around the skin. Bony prominences are not compromised by the cast pressure. Figure 39-5, an external fixator holding fractured bones in place. Devices used to prevent problems of immobility. Specialty beds, air fluidized beds, which have tiny silicone beads contained within the bed under a flexible, air-permeable filter sheet. Low air loss beds, achieved by distributing air through multiple cushions connected in a series. Continuous lateral rotation beds. Bed turns in an arc up to 80 degrees and can be set to pause on either side for up to 30 minutes. What is one way to determine if a patient would benefit from a specialty bed? Most facilities have a Braden or Norton scale that is charted every 24 hours. The areas assessed may include patients' overall condition, mental state, activity, mobility, nutrition, and incontinence. If the total number is below his recommended number, the physician is notified and a specialty bed may be ordered. How many hours of CPM use are recommended per day? Usually a minimum of 6 hours spread out in 2-hour increments. What department is most involved in teaching exercise to the patient? Physical therapy. Figure 39-6, Clinitron Alexis Air Fluidized Therapy Unit. What complication of immobility would this device help to prevent? Air fluidized therapy is effective in the prevention of pressure injury and helps reduce generalized body pain common among bedridden patients. Figure 39-7, Rotorest Delta Continuous Lateral Rotation Kinetic Therapy Bed. Note the foam arm support, thoracic side support, head and shoulder support assembly, head, shoulder, and base pack, safety straps, arm and leg supports, foot supports as well. Rotarest Delta Continuous Lateral Rotation Kinetic Therapy Bed decreases the risk of lung collapse and hospital-acquired pneumonia, facilitates normal urine flow, reduces the risk of developing DVT and PE by encouraging venous flow, decreases skin breakdown. The bed continuously rotates to prevent accumulation of respiratory secretions. Devices used to prevent problems of immobility continued. Pressure relief devices aid in reducing skin trauma from pressure for patients in standard hospital beds. Foam and gel pads, sheepskin pads, heel and elbow protectors, pulsating air pads, water mattresses that lie on top of the regular mattress. Figure 39-8, alternating air mattress pad. Figure 39-9, heel protectors help prevent skin breakdown. Devices used to prevent problems of immobility continued. Continuous passive motion machine, often ordered to restore joint function after orthopedic surgery to replace a joint. Used to exercise the extremity and joint, thus preventing contracture, muscle atrophy, venous stasis, and thrombus formation. Usually ordered in 2-hour increments. Figure 39-10, continuous passive motion machine for the knee joint. Therapeutic exercise. Physical therapy often ordered for patient who is immobilized for an extended period of time. Physical therapy designs the exercise program for the patient. Full range of motion exercises should be performed either actively or passively several times a day. To prevent joint injury while performing passive range of motion exercises, support the limb to be exercised above and below the joint. Nurses can assist with exercises in the absence of physical therapy. Question number 1. Sharon's patient has had restrictive movement for a long time. One major complication Sharon's patient might develop is: number 1, hypostatic pneumonia. Number 2, aspiration pneumonia. Number 3, paresthesia. Number 4, generalized weakness. Question 2. Sharon's patient has a continuous passive motion machine. This machine is used to turn the patient every 2 hours. Number 2, have her cough and deep breathe. Number 3, provide immobilization to a fractured area. Number 4, exercise the joint after a joint replacement surgery. Question 3. Sharon is working on an orthopedic floor. How often should she inspect casts for cracks, crumbling, pressure problems, and infections? Number 1, every 2 hours. Number 2, every 4 hours. Number 3, every 6 hours. Or number 4, every shift. Question answers. The end.